As Sydney mentioned, we're going to cover some regulatory reporting updates for 2025. A lot of that will focus on the Promoting Interoperability Program. We'll also touch a little bit on some of the quality measure updates for this year. So just a little bit about what we'll cover. Introduction of the Promoting Interoperability Programs, just kind of give you a brief overview. We'll touch on the program objectives and measures and any changes that may have occurred since last year. Talk about the program scoring. So as Sydney mentioned, with that Sooner Select program, you can get elevated reimbursement rates through Sooner Care here in Oklahoma. After viewing this program, you will see that your Medicare incentives can either increase or decrease up to plus or minus 9% through these programs. So always a good opportunity to have just options for additional reimbursement. We'll go over the program scoring, as I mentioned, the quality measure updates, and then give you some resources to be able to refer back to. So we'll start off with clinician participation. When you hear promoting interoperability, that's kind of synonymous with meaningful use if you've been in the healthcare, health IT space for a while. The meaningful use program is what this all started out as. It switched to advancing care information and now has moved on to promoting interoperability. So for clinicians, there are 3 different options for participation in the quality payment program. The QPP is kind of the bigger overarching piece to this puzzle. So you have 3 options. One is the traditional merit-based incentive payment system, or MIPS. The second is alternative payment models, and the third is what are called MIPS value pathways. So those were introduced, I think, 2 years ago now. This past year may have been the first year that you could participate in them. But just another similar program to MIPS, but with a more specific focus depending on what your practice specialty is. So do you have to report for promoting interoperability for all options? The answer is yes. The same promoting interoperability measure set is required for all of these 3 different participation options. The quality reporting requirements are going to differ. So traditional MIPS, you're going to have to select 6 quality measures that you submit through the quality portion of the QPP. With alternative payment models such as ACOs, those are going to have their own quality measure set. So that's kind of going to be the difference in your programs. But everybody reports to the promoting interoperability section. That's more or less to just show that you're using certified EHR technology, so a way for Medicare to evaluate that. Also, this promoting interoperability for clinicians is just one part of the QPP. So you have promoting interoperability, which is your EHR measures. You have your quality measures, where you'll have to report 6 of those in traditional MIPS. You have your improvement activities, and then you also have costs. We've done some office hours in the past covering specifics about each one of those sections. So those should be available on the website for you to refer back to if you have more questions about other parts of this program. For hospitals, again, their program used to be called the EHR Incentive Program and referred to as Meaningful Use. This has now changed to the Medicare Promoting Interoperability Program. So promoting interoperability for clinicians is one of 4 performance categories. For hospitals, it's its own separate quality payment program. So for eligible hospitals or critical access hospitals that receive federal funds for Medicare, they are required to participate. If you don't participate, you're subject to a downward payment adjustment. So as I mentioned, clinicians can either get up to a positive or down to a negative 9% increase or decrease for how they do on the performance indicators. For hospitals, there's no increase in reimbursement. You are more or less doing this to avoid penalties. So the penalties for subsection D hospitals, that's going to be a reduction in the increase to the IPPS rate. So say the increase to the IPPS rate is 2% for this year, you would only get 25% of that increase. So you'd get 25% of that 2% increase instead of the full 2%. Critical access hospitals, if they don't meet the standards for this program, then they have a reduction to the reasonable costs, and that's dropped down to a flat 100% rate. So objectives and measures for the program, both hospitals and clinicians, this part is going to be very similar. There's just a few slight differences, but you're going to have 4 overarching objectives, and then there's going to be a couple measures under a lot of the different objectives. So your first one is e-prescribing, then you have your provider to patient exchange, health information exchange, and public health and clinical data exchange. So we'll talk about e-prescribing and the provider to patient exchange first. Your e-prescribing objective is going to have 2 different measures. The first is e-prescribing. So that just means that the prescriptions that you write are transmitted electronically using certified EHR technology. That's going to be worth 10 points for your overall program participation. So that does have to go through the SureScripts network. You do have to use the e-prescribing module within your EHR system. So if you're faxing or e-faxing that, that's not going to count. It does have to go through that e-prescribing module. The second part of the e-prescribing measure is the query of the prescription drug monitoring program. So for at least one Schedule II opioid or Schedule III or IV drug that's electronically prescribed, the hospital or clinician has to conduct a query of that prescription history. This one is also worth 10 points, and I've included a link here to the Oklahoma Prescription Drug Monitoring Program, where if you're not registered, you can get registered. What you want to do to make sure on these measures that you don't report a numerator or denominator is that you have additional information to support in case of an audit. So what we recommend doing is going into the PMP, just taking a screenshot, making sure you're blocking out any patient identifiers if any of those are on there, but just showing you have access to the system, showing that you queried on at least one patient during that reporting period. The e-prescribing measure will be reported as a numerator denominator. So the higher percentage that you get for that measure, the higher you'll get on those points. The query of the prescription drug monitoring program, that's an all or none. So as long as you query at least one of those prescriptions sent electronically, you'll get that full 10 points. The second objective that we'll talk about is provider to patient exchange. So there's just one measure under this objective, and that is provide patients electronic access to their health information. In the past, under meaningful use, this was known as the I'm sorry, I'm going blank. The patient portal. Sorry about that. So patient portal is kind of what this is referring to. Patient portal is just one way that you can access that information. So it can be made in a variety of different ways. But patient portal is kind of the buzzword that people think of when they hear the provider to patient exchange. So for this measure, the patient has to be provided timely access to view, download, or transmit their health information. So those should all be features that are built into your EHR if it's certified. You should have the option to do any of those. Then the hospital or clinician also has to ensure that the information is available to access using any application of their choice. So the patient has a choice on how they want to view the information. That does have to be configured to the technical specifications on the back end through that application programming interface. So they can't just come up and say, hey, I want it in this like health app I've got on my smartphone. It does have to be able to connect to the EHR, and it has to be certified for that. But just know that that is kind of a back-end functionality related to that measure. This patient portal or provide patient electronic access is worth 25 points. Again, that's going to be a numerator denominator that you report, and the higher percentage is going to get you more points on this. One thing I will point out on this specific measure is that there is a caveat within it that says that if a patient comes in multiple times during the reporting period, it does need to be offered the first time and each subsequent time if they're not connected after that. So if a patient declines, you do need to still try to offer them that information the next time that they come in. Also, depending on how your EHR system calculates it, you could miss out on getting credit in the numerator if you don't offer them access the first time that they come in. Just so make sure, especially since we're in January, the start of when a lot of people are doing their reporting period, that you're getting access to that patient portal in a timely manner. The next one is health information exchange. So this is the third objective within the overarching promoting interoperability program. Health information exchange has changed over the past couple years as far as a measure for this program. We now have 3 different options to report. So the first option is you can submit 2 different numerator and denominator measures. The first one is support electronic referral loops by sending health information. So for this, you create a summary of care record and you electronically exchange it with another healthcare entity. So this sending health information is for any of those outbound transitions of care or referrals that you have. The second part of that is to support electronic referral loops by receiving and reconciling health information. So this is the opposite when you're on the receiving end of that transition of care. So whenever you are importing that continuity of care document back into your EHR, you do need to reconcile clinical information. So that's going to include the patient's medication, their allergies, and their problem list, just to make sure that that aligns with what you've got documented within your system as well. So if you choose this option 1, you submit these 2 separate numerator denominators of how many outgoing and incoming transitions of care you have, and then how many of those you received and sent electronically. So each of these measures is going to be worth 15 points for a total of 30 points for this specific objective. There's no exclusion for hospitals currently, so they are required to submit this measure. Clinicians, if you have fewer than 100 referrals or transitions of care during that reporting period, you can exclude this measure. What I will say is some people who may have qualified in the past for that exclusion may not be able to for 2024 and 2025. The reason being is because the minimum reporting period has jumped up from 90 days to 180 days. So if you are just on the threshold of meeting that exclusion with this required 180-day reporting period, you could likely fall outside of those standards. So just make sure you're aware of that if you're looking to claim an exclusion for this measure. The second and third option for this are going to be just a yes/no attestation. So this is more of having a technology in place. And again, any of these yes/no attestations that you have, make sure that you've got supportive documentation to provide in case you get audited for this program. So option 2 is health information exchange, bidirectional exchange. So for this, you must include data on all unique patients, not just a subset. So if you're participating in a bidirectional HIE, you can't just participate with a specific subset. So say, oh, I'm going to send this specific group of patients information to the network, but not everything. So it's kind of an all or none. All of your transitions of care and referrals need to go through that network. You must exchange across a broad network of unaffiliated partners. So an example of that is several electronic health records have their own kind of HIE and exchange data within it. You do have to exchange with other entities that are outside of your EHR. So that's what they're saying as a broad network. Or it has to be outside of one large health system. So if you're part of a big health system, you just exchange information within. That's not going to qualify for this HIE bidirectional. It does have to be a bigger group of unaffiliated partners. For this one, if you attest yes, you get the full 30 points, and no, if you attest no, then you don't get any. So same option, same principle here for option 3. This is just enabling exchange under TEFCA. TEFCA is more or less a national framework agreement. Commonwealth, I think, is one that I'm familiar with and have worked with some practices here in Oklahoma. So you can look on the Office of the National Coordinator's website, and they've got several different entities that are part of this TEFCA exchange framework. So same thing with this. If you're participating, you're sending all of your patient population through that framework, then that's going to qualify and you get the full 30 points. If not, you'll have to either participate with the bidirectional exchange or you'll have to do the numerator denominator objectives. So again, 3 different options, all worth 30 points. Could be submitting numerators and denominators or just a simple yes or no attestation, depending on what you're doing. I do want to mention here, since this is our office hours with My Health, that My Health does qualify as a bidirectional exchange. So they can satisfy this measure for you if you're connected and submitting your patient data to My Health. So their provider portal can kind of help with better monitoring, improving care. This is the bigger picture. So yes, it's going to check a box for this specific reporting program, but we really want to do it to improve care. It can also help to reduce healthcare costs associated with that redundant testing, hospital admissions, emergency department visits. So if you're connected to the My Health network, you're going to have access of all of this information, no matter where your patient goes within the state. You'll be able to see that information within the HIE. Can help improve care coordination during transitions between healthcare settings. So again, that's taking the place of you having to do the sending and receiving, generating that continuity of care document in your EHR and trying to find a direct address or some other method to get that information to the referring party. My Health can kind of take all of that out of your hands for you. It also helps to improve the patient's experience and then improve quality of care for Oklahoma. And this is just kind of a screenshot of what it looks like. You can log in there to the provider portal, see your register of patients, again, and be notified of any of those, admissions that they've had, if they've seen another provider somewhere. So just lets you get a bigger picture of that clinical history for that patient. My Health does also have other tools like their clinical data integrations, their care gaps reporting, and also single sign-on. So they do have that ability to embed that within your EHR. So just with the click of the button, you're able to transition over and see the My Health, not having to toggle between screens. So a lot of great functionality there. And again, can meet that bidirectional exchange measure for you. So you're not having to report the numerators and denominators for that measure. The 4th and final objective for the Promoting Interoperability program is public health and clinical data exchange. So for clinicians, you have 2 required measures that you have to do, and then the rest of them are optional. If you report on the 2 required measures, those are going to be your immunization registry reporting and then your electronic case reporting. You can also attest to additional measures and get up to 5 bonus points if you're connected to an additional registry. So that may be something to look into if you're not performing well on some of those other measures. If you report those 2 required measures, your case reporting and your immunization registry reporting, you will get the full 25 points. And then any optional public health reporting that you do, you'll get those 5 bonus points. It is capped at 5. So say you're connected to 5 different registries, you're only going to be able to get that 5 bonus points. I do want to mention, and I've actually got a slide a little bit later, but there are 2 different options for this. So you do have to be in active engagement. That doesn't mean that you have to be fully live and submitting electronic data. You can be in option 1, which is that pre-production and validation. So that's, say you signed up with the state immunization registry, you're ready to go through that testing and validation procedure, but they haven't reached out to you to schedule that yet, or say you're waiting on some information back on your EHR to get that process going. As long as you've registered to report within 60 days of the start of that reporting period, then you can still say yes for this objective. So being in that testing and validation does count as a yes option on this yes/no objective. The second option is just that validated production data. So that's you're live, you've gone through the testing, and you've got electronic data flowing from you to that public health entity. For hospitals, it's a little bit different. So you have some similar reporting options, but you are going to be required to attest to, oh, and sorry, I should have changed that. It was 4 measures last year, it's 5 measures this year. So your required 5 measures are going to be your immunization registry reporting, syndromic surveillance reporting, electronic case reporting, electronic reportable lab results, and then your AUR, so that's your antibiotic resistance and use measures. So the AUR surveillance measures are the new ones for this year, and I'll talk about those in just a minute. You have to report on all of these 5 public health measures to get the full 25 points. There are exclusions available. So, for instance, here in Oklahoma, I want to say the Oklahoma County Health Department does some level of syndromic surveillance reporting, but it's not available statewide. So, if it's outside of your jurisdiction, then you can claim an exclusion. Claiming an exclusion still gets you credit for that measure. So, you don't fail if you claim an exclusion on one of these. You will just have to report yes or claim an exclusion to get that full credit. Same with the hospitals. You can get up to 5 bonus points if you're submitting to an additional registry outside of the required ones. So just a reminder that that is a good option. There's several. If you just, you can filter kind of by specialty. Also, the CDC has hospital and clinician surveys that you can do that would count towards this public health reporting. So lots of options out there if you're needing some additional bonus points. I wanted to show this. So this is public health reporting options through the Oklahoma State Department of Health. They've got several options that you can use to meet these measures as far as clinical data reporting. They do accept the immunizations, they accept the reportable lab results. They also have options for a COVID registry, cancer case reporting. They even have BMI. What I do recommend is that you reach out to the state either through this meaningful use email address or the electronic reporting at health.ok.gov just to make sure that that specific registry qualifies. There are some differences for hospitals and clinicians. Clinicians aren't required to report that reportable lab results. So reach out to them to make sure that you're reporting to the right registries to get credit for this program. But there are several options through the state of Oklahoma to get credit for this. And then the AUR surveillance. So this is the new one for 2025. So completion of this measure shows that the eligible hospital or critical access hospital is in active engagement with the CDC and the NHSN network to submit this data. So this is a new measure you'll submit through NHSN. Again, you've kind of got the same active engagement options. So within 60 days of the beginning of your reporting period, whatever 180-day period, or if you're using the full year, make sure you're doing it within the first 60 days of the year. But you'll have to register with NHSN to submit this data. You, again, can be in that validation and testing protocol and still get credit for it. For these new measures, they do have a couple of different exclusion criteria. So if you don't have any patients or any patient in the care location for which the data is collected during the reporting period, then you would be excluded. If you don't have access to an electronic medication administration's record, so that EMR, barcode medication administration, or an electronic admissions discharge transfer system during the EHR reporting period, you can choose to exclude this measure. And then also, if you don't have an electronic laboratory information system or electronic ADT system during the reporting period, you can exclude this measure as well. Again, excluding the measure does give you credit towards the measure, so it won't fail you for that whole objective. But make sure that you are either registered with NHSN and kind of in the waiting list. Since everybody's having to report this year, that waiting list could take several months. So again, as long as you're registered, you'll get credit for that. But make sure you've got this process going to get full credit for the public health objectives this year. I mentioned this earlier, so I'll just briefly touch on it. But for your public health reporting, you have to, when you're attesting, you'll have to say what active engagement option you're in. So option 1 is that pre-production and validation. So registration was completed 60 days after the start of your EHR reporting period. You're awaiting an invitation to begin testing and validation, or you've begun that testing and validation process. And then the third kind of qualifier here is that you must respond to any requests from that public health entity within 30 days. So say NHSN reaches out to you, you have 30 days to respond. If you fail to respond twice to their correspondence, then you would fail for that measure. So just make sure you've got correct contact information in there and you're responding to any requests from that public health entity within a timely manner. And then option 2 is that validated data production. So you've completed all the testing, you're electronically submitting data, and you're good to go. But as you're attesting to this information, you will have to select which, if it's a yes, no, or exclusion for each of the required measures, and then also if you're in the pre-production or in the validated data production category. Just a little scoring overview. So your e-prescribing, again, you can get anywhere from 1 to 10 points for that e-prescribing measure. You get the full 10 points as long as you query one of the prescription drug monitoring drugs that's sent, do a query of that program. For the health information exchange, if you choose to do option 1, which is where you're submitting the 2 separate measures for the transitions of care, you can get up to 15 points for each of those. If you do option 2, so if you're connected to an HIE like My Health and you have that bidirectional process in place, you'll just get the 30 points by saying yes. Or option 3 is that TEFCA option. Your provider to patient exchange, so this is your patient portal. If you're giving patients electronic access to view, download, and transmit, you'll report the numerator and denominator for that and can get anywhere from 1 to 25 points. And then your public health and clinical data, the clinicians, you've got the 2 required measures, and then you can get 5 bonus points if you submit another. Hospitals, that should say 5 now with that AUR measure. So hospitals have the 5 required. As long as you claim a yes or exclusion, you get the full 25 points, and then 5 for any bonus measure. One caveat is that you do have to have at least a 1 numerator for each measure to receive a score. So if your e-prescribing is 0, or if your health information exchange option 1, if any of those are 0, or your provider to patient exchange, if you don't report at least a 1 numerator for each of those measures, you'll fail for the whole program. So just make sure that you've got data to submit for each of the required measures. So scoring for traditional MIPS, this is going to be on the clinician side. Promoting interoperability is 25% of your overall score. If you're participating in an advanced model, so like an ACO, for those APM participants, it is going to be 30% of your overall score, so slight difference there. You'll take the total points from the measures that you get. So what we just showed you in the scoring table there, multiply that by 25 or 30% to get your overall performance category score. For clinicians, you'll have additional points that come from other performance categories. So again, your quality, cost, and improvement activities. For hospitals, the Promoting Interoperability program is separate. So you'll have to avoid penalty, which we talked about the differences in the subsection D versus the critical access. So for any eligible hospitals, you have to have a total of 70 points across all of the measures to avoid that penalty. That 70 points is up from 60 last year. So last year, or you're probably getting ready to report this data for 2024, will be due at the end of February. So for 2024, you need a total of 60 points to avoid penalty. For 2025 that you'll report at the beginning of 2026, you'll need 70 total points to avoid penalty. Now, just a few brief changes on clinical quality measures. So for providers, those clinical quality measures are a separate performance category within MIPS or within your APM. So for clinicians, you've got 7 new quality measures that you can choose from this year. There's a list of a couple hundred on the QPP website, so you can narrow that down by specialty to get a little bit better idea of what would be measures pertinent to your practice. You do also have to be aware that those measures need to be certified within your specific EHR. So you do need to make sure that those are available within your EHR. That may kind of help you narrow down which quality measures you're going to attest to. They did remove 10 quality measures from the list. So a lot of those are either topped out because people have been reporting them for a while, or they don't have an accurate benchmark to be able to put those measures against. So for some of those measures, they get removed and retired. And then there's changes to 66 existing quality measures. So that's typically just in the way that those measures are calculated or what the benchmarking is for you to get points on those. So your new clinician quality measures for this year, you've got excessive radiation dose or inadequate image quality for diagnostic computed tomography in adults, positive PD-L1 biomarker expression, appropriate germline testing for ovarian cancer patients, adult COVID-19 vaccine status, melanoma tracking and evaluation of recurrence, first year standardized waitlist ratio, and then percentage of prevalent patients waitlisted and percentage of prevalent patients waitlisted in active status. So a lot of these are going to be very specialty specific, but again, the MIPS in promoting interoperability apply to a variety of different providers, not just primary care. So again, making sure that you're filtering that list by specialty and aware of all those options available to you. This is a list of the clinician quality measures that have been removed for 2025. So I won't read them all. Again, we will send out the slides afterwards so that you have that information available. For hospitals, you do have changes in quality measures. These quality measures you will see for hospitals through the Promoting Interoperability Program. You are required to submit your ECQMs through that program. If you participate in the hospital IQR program or OQR, as long as you are submitting that data through QualityNet, or it's called something different now, the Hospital Quality Reporting Portal. If you're participating through the IQR, you will get credit for electronically submitting those ECQMs for promoting our interoperability. So you don't have to do it twice, but just a couple of different reporting options there. So the changes for hospital quality measures, you've got new hybrid measure changes. So the voluntary instead of mandatory for the pre-op data. And then 2 new structural measures, your patient safety structural measure and your age-friendly hospital structural measure. So for the hospital hybrid measures, you have a total hip arthroplasty and your total knee arthroplasty patient-reported outcome-based performance measure reporting. This is going to be voluntary in 2026 and then mandatory in 2027. So your reporting periods for these are listed and your submission deadline is listed there. So September 30th of 2025 for that voluntary reporting period, and then should be September 30th of 2026 for that mandatory reporting period. Your hospital structural measures. So with that safety structural measure, you've got 5 different domains that are included in this. Your leadership commitment to eliminating preventable harm, strategic planning and organizational policy, culture of safety and learning health systems, accountability and transparency, and patient and family engagement. So some of the updates for last year, that you saw in these structural measures were health equity. So this is with health equity, you had a lot of the building into the strategic planning and certain things that you had to do in addition to that social determinants of health 1 and 2 measure. So these are the new structural measures that are getting added on for 2025. So after your safety structural measure, then you also have your age-friendly hospital structural measure. So 5 domains in this as well, eliciting patient healthcare goals, responsible medication management, frailty screening and intervention, social vulnerability, and then age-friendly care leadership. So don't have a lot of details on these new measures, but just wanted to make you aware for clinicians that there have been measures removed and new ones added, and that hospitals, you do have some new structural measures and measures that are optional for this year, but going to be required in the future. If you do have more specific questions about any of these quality measures, you can feel free to reach out to the OFMQ team, and we're happy to get you more details on those to make sure you're meeting those requirements. So that's all we have for the regulatory updates. Before we close out today, I just wanted to touch one more time on the Connection Fee Assistance Program. So again, if you're not connected to MyHealth, the state designated entity for health information exchange here in Oklahoma, now's the time to do it. We have this Connection Fee Assistance Program available that will cover all of those one-time connection fees through state grant funding. So make sure that you're going to this link here to OK Shine, sign up for that. The first step is that you fill out a participation form to participate in MyHealth. And then the second step would be that you fill out that connection fee assistance form. If you don't know how to get to the MyHealth form, you can either go to their website, or as you're going through this and filling out the connection fee, that's the first question I'll ask you is, have you completed an application to join MyHealth? If not, it'll take you directly to their page. You can get that filled out. If you need any assistance with these processes, you can reach out to one of our team members here at OFMQ. We've got their information listed down here below. Shoot them an email and they can walk you through the process. Not a problem at all. And again, just a reminder that there are incentives to participate in this. So if you are in good standing with the Health Information Exchange, MyHealth, then you do get some additional funding through that Sooner Select incentive program. So again, just another added bonus of connecting to the HIE here in Oklahoma. And then just a few resources. So the QPP resource library, that's going to be your resources for all your clinicians. That will show you not just the promoting interoperability, but the other required parts of the program too. So your quality, your improvement activities. The PI programs resource library is going to be anything for promoting interoperability for hospitals. And then also just have your MyHealth application and the connection fee assistance application listed here for you as well. And with that, we'll close out and kind of open it up for questions.
I do see a question in chat, Sydney.
Yeah, it looks like at 12:41, we had a question, is the Indian Health Service part of this? So I'm not specifically sure if they were talking about a specific reporting requirement at that moment.
Yes, so IHS facilities, both physicians and hospitals are still part of these promoting interoperability programs. If you do have questions about a specific provider at one of your sites, you can go to the QPP lookup tool. If you just Google that on the QPP website, there's a place you can enter your MPI number, and it will tell you whether or not that clinician is eligible for the program. IHS hospitals, yes, they are required to participate in the promoting interoperability program as well.
Put that QPP participation status direct link in the chat too. Any other questions before we close out today's session? It's almost 1. No pressure. All right, well, seeing none at this moment, thank you all for joining us today for our HIE office hours session on 2025 regulatory reporting. As a reminder, you'll receive a follow-up email soon with a PDF copy of today's presentation, along with additional information on the OK Shine Connection Fee Assistance and the Sooner Select Provider Incentive Programs. For any more details, including how to apply for these programs, be sure to check out the chats in the link in the PDF presentation or visit myhealthaccess.net/OKShine. Thank you again for your time and participation. If you have any further questions, don't hesitate to reach out to us. Have a great day and thanks for attending.